let me just await your screen and say part of the genius and the success of the tools that we've built is this operationalize of breaking a comparative effectiveness study up into 5 different components. Each of those components can both be reused for other studies, but if you make this dissection, then it's very easy to then reduce, given these 5 sections, down to the type of study that you're used to seeing, and that can be done automatically. Right? It doesn't actually require human intervention to translate from 5 items down to the study that you're used to seeing. And that's what takes study design down from a year to maybe a couple of days, or in the afternoon, we'll put together a partial study in just an afternoon itself. So what's most important to remember is you need to define a treatment, a comparator, and an outcome cohort. And these definitions are done independently. A cohort is not a code set. It is a set of individuals that satisfy one or more criteria for a given duration of time. In addition to the TC and O, we now need to look at the physiological effects that we're trying to model, and you need to define a time at risk and an outcome model process. So we're going to take these ideas and apply them to a very important, very well designed comparative effectiveness study done by David Graham a couple of years ago, published in Circulation. The PDF of this should have been sent around to all of you. If you haven't printed it out, because I don't own a printer anymore, you should pull up the PDF of David's study right now. And we're going to and it's focused on sort of cardiovascular bleeding mortality risk in an older population who are exposed to one of 2 different types of oral anticoagulants for the indication of atrial fibrillation. What I'd like you to do once you have that PDF pulled up is to partition yourselves up into groups of approximately 4. And one way to do it is here's a group, there's a group, there's a group, unless you have favorites, and sort of each of these, and get ready to work together. Because in those groups of 4, I want you to basically, we're going to go through the question of how could we reproduce David's study. And in order to reproduce the study, we need to define what TC and O are, what the time of risk is, and the outcome model. And then we're going to come together to see how successful we were in coming up with those 5 points so that we can talk about reproducibility and perhaps reproduce this study together as we move on. And we're going to do this all in 15 minutes. 20 minutes.
You can please find the email if we don't know if we got it.
So, honestly, no, but I think Google would bring this up pretty quick, much faster than not.
The email is on Friday, October 5th, 8:48 a.m. October 5th, you can look at the date.
So one of the aspects of OHDSI is we strongly believe in open science. Part of open science is reproducibility. And everything that we provide, we hope, is absolutely transparent and reproducible. And so one of the things I want you to look for as we're defining these 5 important bits are kind of ambiguity, or at least a lack of transparency or reproducibility in the information given in the paper. Because ultimately, we'd like to generate evidence that's reproducible and reliable. So here's an example of the types of things you need to look at. Well, we need to define the target and the comparator cohort. So what are the medical concepts that were used or not used in this criteria? But remember, a code set itself is not a cohort. How are those code sets? What is the logic used for those code sets to define the time at which an individual entered and exited that cohort? How did it work? So do we have our groups of 4? All right. Of course, that 20 minutes was absolutely sufficient time to discuss an entire paper. So let's bring ourselves back together, and we'll spend a couple minutes doing it as a group. And I'll make sure that we all have some break time as well before we get back to actually implementing a replication of Graham's study on dabigatran versus warfarin. So to facilitate a quick discussion, I've put up some leading slides. We need to define the target and the comparator cohorts. Maybe you might say it's elderly Medicare beneficiaries with non-valvular AFib who initiated treatment with either dabigatran, which I've picked as my target arbitrarily, versus warfarin. Is that correct? Are those cohorts? There are a lot of inclusion and exclusion criteria. So now we have code sets, right? We have codes or concepts for dabigatran or dabigatran, depending on which coast you come from, and warfarin. And we have, basically code sets for the concepts within the inclusion and exclusion criteria. What else do we need? Cohorts are not code sets. They are... Right, they include the logic for when an individual comes in and out. So we need to define all of those things. So here are some of the inclusion criteria that I put down, which includes some time. But what other ones are we missing? So it's an inpatient or an outpatient definition of AFib. They actually provide a code for what might define that. At least one prescription. Okay, we can find that during a time period. And the index date. So what's an index date in terms of a cohort? Yeah, so it might be the first or our start date for when an individual enters into the cohort, right? We suspect that maybe we will use observations about individuals before that index date.
It's not the first prescription date, but the first fill date.
Filled at least one. Yeah, that's tough in many databases. But maybe important, right?
If you've got claims.
Yeah. I've gotten some prescriptions I've never filled. I've also taken plenty of medications which I've never been prescribed.
Well, they also begin the risk period the day after. So if you do it from prescription rather than filled, you could be saying that they were at risk before they got the medication.
Yeah, so there are lots of other inclusion and exclusion criteria. One point I want to get to before we get to the other ones is actually how did they define AFib? Are they defined anywhere?
They said that it involves ICD-9, but I didn't see the code.
Yeah, I don't know. Yeah. As part of this exercise, which I think each of you appreciated, is to realize that it's very difficult to answer the complete set of questions that we need to fully replicate this study. Turns out the supplementary material provided a large number of codes for the outcomes. Here are some of the exclusion criteria that they had. There was a good question back here. What's the difference between inclusion and exclusion criteria? Yeah, that's a great answer. None. You just put a not before one of the others, and you can make your life much simpler. Personal opinion, I think, if you have a reviewer that asks, this is a great paper, but you only had your inclusion criteria, where are your exclusion criteria? You could either be flip like me and say, I'm not answering that question, or you could just take some of them and put a not before it and be done with it. There are some questions about kind of the time periods when some of these inclusions had to occur. Like a patient could not be undergoing dialysis, but that begs the question, when? So we need the logic for the time as well. Right, and there are lots of other time questions, but we need to make sure we have a little break. Okay, so we have a target and a comparator cohort. What tools were used in this paper to try to ensure comparability between those two populations of patients? they built a propensity score model, right? So, yeah, propensity score model is a not quite very fancy name just for saying we did a logistic regression. So, who's done a logistic regression in this room? Like, everyone really should raise their hand, right? Who's done a propensity score in this room? Like, no one will raise their hand, except for those that know that they're just a logistic regression where the outcome is treated with one of the drugs. And in this case, treated with dabigatran. Does it matter which one you pick? No, right? It's a linear, it's a generalized linear model, so it's like symmetry in which we have. Our convention in OHDSI is its probability of treated with the target drug. Purely a convention. What predictors went into this?
But logically, I mean, if a drug has been out on the market for a long time, you would compare new treatments against existing treatments.
Right.
Targets tend to be.
Yeah. But it doesn't matter.
In replicating this study, you might want to pick dabigatran as a target because that's the reference in warfarin. Paper, warfarin is the reference.
Yeah.
So it makes sense.
Yeah. So they did a logistic regression using what covariates? A lot. Or maybe not a lot. Well, they used sociodemographics. What does that mean?
Rates?
Maybe? Maybe? I don't know.
Yeah, in Medicare data, you do have geographic distribution plus the social income by the different category level for Medicare data.
So maybe they use that.
Yeah, I think they use that.
Right? But the point is maybe. So I don't want you to get the impression that I'm saying this is a horrible paper. In terms of comparative effectiveness studies, this is a fantastic paper. But we can always do better. What's up? Yeah. Well, I've seen a lot of really bad papers that did a lot of work. So they built a logistic regression on other potentially relevant covariates. Great, I always like to include those, but I like to be a little more explicit of what they were. They did a 1-to-1 ratio greeting matching on that propensity score, and they assessed balance by looking at standardized differences of means. Was balance achieved? They did greedy? Yeah, they did greedy match. Yeah. What is greedy matching? So in picking matching, so items which have the closest similar numbers on between 0 and 1 is an optimization problem that is really challenging to solve exactly. So to find each pair that actually have the smallest difference in standardized difference. So instead of finding the optimal matches, they found something probably close to the optimal match that can be run in relative time using a greedy approach. So you solve a subproblem and you say that subproblem is correct. Don't worry too much, it's all greedy. So yeah, things were balanced afterward. Okay, maybe they were balanced before, were they?
Well, I don't know that there's two diagnostic tests they didn't do. Even they used all the variables, I don't know exactly how they define exactly how many. At least if they give total variable into the model, I have a general sense how many they control for.
Yeah.
But just like listing 4 categories, I don't know how they did it. For example, based on the HRQ, the comorbidity classification, you have about 1,000 variables.
Yep.
Right? So based on our standard combinated model probe, you under thousands, hundreds of thousands.
Yeah.
Theirs could be somewhere in between, but if they tell me they enter 2,000, 3,000 variable, I say that's reasonable probably.
Yeah.
But remaining, I don't know you balance. And the additional diagnostic, again, come to negative control is there residual bias, which is we don't know.
Yeah.
But on paper, I think if you look at standardized difference for all the variable entering the model, I believe they probably all balanced.
Yeah.
That doesn't mean the other ones.
No, it doesn't mean everything that we don't have is not balanced. Right? And even having 100,000 other features that we can arbitrarily construct doesn't mean there's the 100,001 that's actually important that remains unbalanced. The outcome, well, they were looking at the risk of either stroke, major GI bleed, MI, or mortality, for which they provide code sets. Yeah.
with some code sets. What assurances do they have that they have all of the appropriate codes in their specific data that might represent these events?
There's a precedent.
Yeah, what are they? How do they talk about their outcome definitions?
They said adapted from a different article.
Yeah, they say taken from a different article. Do you report a positive predictive value?
We did.
People like positive predictive values? I'm not raising my hand. It's only half the story, right? Is positive predictive value, and you need one other statistic to really learn about the sensitivity and specificity of an outcome. Don't worry, we have very little time. So we have an outcome, we have a time at risk. They did fit a Cox proportional hazards model, which allows us to use a large amount of information in that data. So it's the time after index date to the first event, or censoring, or we basically say they're no longer at risk. Here are some of the criteria that I've listed for what those possible censoring times could be. Did I miss any? Probably. And were there other time at risk definitions? Yeah. How can I tell? Because it probably, does it say Cox proportional hazards model? Yeah, so it is a survival model. And that, in a time to a first event is, well, a time to an event is a survival process. The other choices that we kind of went over in some of the groups earlier, you might do the number of events that happened, or did an event happen, yes or no, within a specific time period.
Yeah, when I was reading that paper, I never understand it in terms of greater than 3-day gap.
Yeah, I didn't get those things either.
I mean, in practice, that's almost impossible, especially for warfarin, because of those changing modified doses on marijuana. But even for that gap in 3 days, we always know what if anybody take medication before, for short-term antibiotics, you always get the medication before it runs out, and then someday you forget one pill, you're overlapping. 3 days seems like, I don't know how they take that one, that's just never comprehensive to me when I read the paper originally. I thought that day just like doesn't make any sense at all.
At this point, I'm going to have to take my other hat and say, I'm just a statistician. I can't claim to understand. I'm sure there's very good, I'm sure there's some sound expert knowledge or expert opinion. So bioavailability is down.
Well, I interpret that 3 days when censoring patients to call the continuum treatment, right? It's not about the half-life at the end of treatment. It's about if you have received medication for 30 days, you got another dispensing 5 days after that one. You now run out, particularly we have 30-day gap, we will say that patient continue on medication. But if I read their statement in the paper, in that case, there will be patients censored at that 5 days because that's beyond 3 days. And that's why I said it doesn't make sense to me. But if that's at the study end, if you plus 3 days, that's so-called biological window, which is we also use in our study. That makes sense to me because warfarin half-life is about 5 to 7 days, that's shorter. But then again, it could be 24 hours to 48 hours, that could okay. But that statement does not refer to the study end, it's referring to me, it's a continued medication definition, so that's why I said use that.
We could try to look at that empirically and ask about a sensitivity analysis. We do make a large number of assumptions about what is the relationship between a pharmacological agent inside an individual and how that leads or possibly could lead to the outcome that we're interested in.
I just wanted to say, with dispensing data, you can't tell if they were on the drug, but you can definitely tell that they couldn't have been because they didn't have enough supply. So
No, that's not true because for especially
as long
for
as you're tracking
but that gets for chronic use or diabetes, patient also receiving about 30 days, sometimes even internet dispensing could be 90
from
days.
their
90-day supply.
So if you calculate the dispensing records, you calculate 30 days, but sometimes you always miss pills in the middle. Everybody does. So when you have missing it, even on paper, you only
I
cover
see.
30 days.
Right.
You actually have a 35 days.
Got
So in that period, you still cover. That's
So-
why you have that definition.
So let's lump these difficulties into residual bias or systematic error. Okay? What type of approaches here were taken to ask, is this a reliable estimate? You know, we have an observational study. Is it really a unbiased estimate of the causal effect? So what was done? They certainly looked at comparability between treated and, well, between the target and comparator cohorts, right? That's very important. They provided some diagnostics for that. What could be done, and could be done if you can operationalize your definitions into T, C, and O independently, is you can inject a large number of other O's, O's that are believed to not be associated with treatment from either dabigatran or warfarin, and ask what is the distribution of these negative controls relative to the estimate that we get for our positive here. And in providing this distinction between T, C, and O, time at risk, and outcome model, allows that possibility. So not only do we get the full diagnostics for comparability between cohorts, but we can also do positive and negative controls to control for kind of measured residual bias, or a large number of these other questions that we have about what is the underlying biological process going on. So that being said, it's a great paper, hard to reproduce exactly, has almost all of the information that one needs, and we'll go through an exercise after break where we do that type of reproduction.